Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at California Health Sciences University, and today we will be discussing heparin-induced thrombocytopenia. And the reason we're discussing this topic today is because though heparin-induced thrombocytopenia is typically a rare occurrence, typically occurring in less than or about 1 in 5,000 hospitalized patients, heparin-induced thrombocytopenia can cause complications that may promote morbidity as well as mortality. So our objectives today will be to diagnose heparin-induced thrombocytopenia. We're going to list the different causes of heparin-induced thrombocytopenia, which are mainly medication-related. We're going to compare and contrast medications used for heparin-induced thrombocytopenia and describe transitioning a patient to oral anticoagulation post-heparin-induced thrombocytopenia. So we'll start off with the case. CG is a 53-year-old female presenting initially to the ED with altered mental status as a result of pneumonia. 5 days into her admission, the healthcare team notices that her platelet count has decreased to 120,000 per cubic millimeter. To note, upon admission, CG's platelet count was around 300,000. She's currently on heparin 5,000 units sub-Q 3 times daily for DVT prophylaxis while in the hospital. A 4T score is calculated to be 5. What is the probability of heparin-induced thrombocytopenia or HIT in this patient? Is there no risk? Is there low risk? Is there intermediate risk? Or is there high risk? The next question is, which is the most appropriate intervention to make at this time for patient CG? Is it to discontinue all heparin products, obtain a PF4 heparin IgG amino acid and start enoxaparin? DC all heparin products, obtain a PF4 heparin IgG amino acid and start Argatroban? DC all heparin products, obtain a PF4 heparin IgG amino acid and start warfarin, or continue all heparin products as a diagnosis of HIT is unlikely. And the third question, once CG's platelets recover, which oral anticoagulant should CG be transitioned to? Essentially, once a platelet recovery of above 150,000 occurs. Is that agent apixaban, dabigatran, enoxaparin, or warfarin? Once we discuss heparin-induced thrombocytopenia today, we should be able to answer all of these questions. So just to give you a little bit of background regarding heparin-induced thrombocytopenia, it occurs, like I said earlier, in about 1 in 5,000 hospitalized patients, which doesn't sound like many patients in general, but whenever you do have a diagnosis of HIT, it can be pretty severe. And thinking about the amount of patients that come into any one hospital during one day or even 1 month or 1 year, that can potentially amount to several patients that you have in the hospital with HIT during those time periods. The incidence is about 1 to 3% post-cardiac surgery. Cardiac surgery is a potential risk factor for the development of heparin-induced thrombocytopenia, and that has been observed among other risk factors. Of note, the most significant complication, which is thromboembolic complications, may occur in approximately 50% of patients with confirmed HIT, particularly if HIT remains untreated. It's been noted that of patients who are not treated for heparin-induced thrombocytopenia, that about 30 to 50% of them will actually have a thromboembolic or other complication related to their heparin-induced thrombocytopenia. So it's important to treat heparin-induced thrombocytopenia if you see it occur. So to understand HIT, you have to understand at least a baseline pathophysiology of what HIT or heparin-induced thrombocytopenia is. And as you see, this figure here, which is actually published in a review article in New England Journal of Medicine, looks very complicated. Essentially what happens here is that HIT has a lot of similarities to your bacterial host defense system, which you probably learned a little bit about in immunology and your immunological studies prior to this class. Of note, PF4, or platelet factor 4, is released from platelet alpha granules. And whenever a patient is administered heparin or a heparin product, such as unfractionated heparin like Lovenox or enoxaparin, essentially what happens is there is a binding of this platelet factor to the heparin or the Lovenox. And essentially what that will happen is that PF4 and heparin will actually form a complex that you see right here. Once that complex has formed, B lymphocytes will actually generate anti-PF4 IgG antibodies, and these can actually bind to not only bacteria, but actually to those PF4 heparin complexes that forming a massive immunocomplex that you see essentially here. As a result of that platelet activation and aggregation, because your platelets are now aggregated, essentially your platelet count may decrease. And typically this occurs over a period of a few days, in most cases at least 5 days, though depending on the type of heparin-induced thrombocytopenia that you have, it may actually be a spontaneous occurrence occurring in less than 1 day. So as a result of this platelet activation, essentially what you have here is a generation of thrombin. And thrombin is essentially one of our clotting factors in our clotting cascade that you learned about whenever you talked about basic anticoagulation. And that thrombin production can actually go to eventually increase the risk of developing thrombosis. In addition, because you're forming these complexes, you essentially will have a decreased platelet count that occurs here. And that's where essentially the term heparin-induced thrombocytopenia comes from. So essentially it's a syndrome of a platelet decrease as well as an increased amount of clotting. So essentially that's what I essentially want you to get from this picture, is that you have increased thrombin production and a decreased platelet count, which is typically above 50%. And that may present with or without thrombosis as a complication. So in terms of things that can cause heparin-induced thrombocytopenia, just as the name says, heparin is one of the main causes of heparin-induced thrombocytopenia. So heparin, as we know, is an unfractionated form of heparin, or UFH. In addition, low molecular weight heparins, or LMWH, also have a risk of inducing this HIT, or heparin-induced thrombocytopenia, though typically it's about 10 times less risk of occurrence compared to regular heparin. And the agents that are included in the low molecular weight heparin class are enoxaparin or Lovenox in dalteparin fragment. Typically, the agent that we see a lot of times is enoxaparin or Lovenox in the United States. So, how do you essentially go about calculating or diagnosing heparin-induced thrombocytopenia? So if you start seeing a drop in platelet count and your patient is on one of these heparin products, either heparin, Lovenox, or dalteparin or fragment, if you have a significant decrease in platelet count, you may want to diagnose HIT. And whenever you try to diagnose HIT, what you need to do first is calculate what's called a 4T score. And a 4T score contains essentially 4 components. It assesses the degree of the platelet drop, also known as acute thrombocytopenia, the timing of onset. So how quick did that platelet drop actually occur in? And typically these are measured in the amount of days, because this process and pathophysiological process can take days to occur, though, like I said, it can be spontaneous in some cases, depending on the mechanism in which it occurs. You may have evidence of thrombosis that occurs, like we said, because of the generation of thrombin in this pathophysiological process. Or you may have other causes of thrombocytopenia that may potentially confound the diagnosis of heparin-induced thrombocytopenia. Because remember, there are many other causes of thrombocytopenia that exist out there. One big cause is medications itself. Another cause is potentially infection. So whenever you go and calculate what's called this 4T score, you can get a maximum score of 8. And essentially there are 2 points per each of these 4 components, so 4 times 2 is 8. Scores of 4 or more, once you calculate your 4T score, will require further laboratory testing to diagnose HIT. So what does this 4T score look like? So essentially from the last slide, I just blew this chart a little bit bigger. So acute thrombocytopenia. So essentially here you see that each different parameter, such as acute thrombocytopenia, will have a point score associated with it, either 0, 1, or 2. 2 being the most significant potentially for a diagnosis of heparin-induced thrombocytopenia. So if your patient has a platelet count decrease of greater than 50%, with your lowest point being above 20,000 platelets per cubic millimeter, then you would get 2 points here. So typically what we see in these patients is that the platelet count will drop by about half. Now if your platelet count is between 30 to 50% decreased from baseline, you'll get 1 point here. And if your platelet count decreases by less than 30%, you get 0 points. Because remember, the platelet count decrease of greater than 50% is typically indicative of HIT. In addition, you also have other criteria that you look at. So another thing you look at is timing of onset. So if your thrombocytopenia drop of at least that 50% or that 30 to 50% or that less than 30% occurred within 5 to 10 days, or on day 1 if your patient has a recent heparin exposure, then you get 2 points. If it's greater than 10 days or the time of exposure is unclear, you get 1 point. And if you have an exposure occur where your thrombocytopenia occurs in less than or equal to 4 days, then in that case you may get 0 points. The other things that you look at are thrombosis and other causes of thrombocytopenia. Thrombosis, if there's a new evidence of thrombosis or an anaphylactoid reaction after a heparin bolus, you get 2 points. If there's progressive or recurrent thrombosis, you get 1 point, and if there's no thrombosis, it's 0 points. In addition, if you have another cause of thrombocytopenia that is existing definitively, you get 0 points because essentially that confounds a diagnosis of HIT. If you have a possible cause of thrombocytopenia, it's 1 point. And if you have no other causes of thrombocytopenia that can be identified, it will be 2 points. This one is a little bit harder to identify in terms of what is possible, what is definitive. Essentially, I don't want you to get burned out too much over these terms of possible versus definitive. I'll kind of give you a little bit of guidance whenever we get to the actual application exercises about what is possible and what is a definitive cause of thrombocytopenia. So once you calculate each of the scores for each of these 4 areas, what you do is you add all of them up. And at that point, if you have a score of 6 to 8, that indicates a high score. If you have a score of 4 or 5, that indicates an intermediate score. And if you have a score of 0 to 3, that's a low score. So essentially what happens here, like I said, if you have thrombocytopenia that you've detected with your patient or thrombosis during heparin use, and typically thrombocytopenia, most of the time we define as a platelet count of less than 150,000 per cubic millimeter. But in some cases, that thrombocytopenia may actually be defined as that profound platelet drop of greater than 50%. So say if your patient's platelet count was 400,000, and then it dropped to 200,000 in the course of 5 to 10 days, that may also be defined as thrombocytopenia, as you've had a profound drop. So if you have either of these 2 things occur with a patient on heparin, then in that case you will evaluate the 4T score and then break it down further by what the score actually is, as we just discussed. So like we said, a patient after you obtain their 4T score has a low probability of hit if their score is from 0 to 3. It has an intermediate probability if it's 4 to 5, and a high probability of 6 to 8. Now, one thing to note about this 4T score is it's not necessarily the best way to actually obtain a diagnosis of it. It's kind of used as a screening tool. And essentially, it's used as a screening tool because it's cheaper than some of the other methods that we can actually use. And because some of the other methods are actually more expensive, they're a little bit harder to obtain. If your patient has an intermediate or high probability of hit as defined by the scores above, at that point you will want to replace all heparin products with non-heparin parenteral anticoagulation, which we'll discuss in a moment, and obtain a PF4 heparin IgG immunoassay. So essentially this score here is very cheap and essentially free, other than the fact that you'll be using your expertise and you can obviously potentially charge for that depending on where you're at. Once you get this immunoassay, then essentially the charges start to rack up. Typically most hospitals will have a PF4 heparin IgG immunoassay available to them in the hospital. Essentially, this immunoassay is kind of evaluating for that aggregation that occurs with that PF4 and that heparin moiety. So if that moiety is negative, hit is essentially ruled out at that point, and it's important at that point then to restart your heparin anticoagulant products, as you may not necessarily need your non-heparin parenteral anticoagulation anymore. However, if this immunoassay is positive, you want to confirm the diagnosis because, again, similar to the 4T score, it's not necessary. This PF4 heparin IgG immunoassay is not necessarily the best tool that you can use to diagnose. However, it is readily available to a majority of hospitals. What you'll want to do is you'll want to confirm the diagnosis of hit with a functional assay, like a serotonin, such as a serotonin release assay or SRA. And essentially, in many hospitals, most hospitals will not have an SRA available to them up front. So you'll actually have to send it out to another lab, which may potentially be out of state even. Once that serotonin release assay comes back, and it may take up to a couple of weeks in some cases to come back, and if that SRA is positive, then hit is likely to be diagnosed. At that point, you'll want to rule out whether or not the patient has a thrombosis or a DVT and document a heparin allergy in the patient's chart. Now, does that necessarily mean that that patient can never get heparin again? Not necessarily. In some patients, you may be able to re-administer heparin again after about 100 days and potentially not have a reaction. However, not all practicing clinicians will necessarily want to give heparin or heparin products to this patient again if they're SRA positive. So you'll want to document in the patient's chart that they are SRA positive. However, if they're SRA negative, HIT is highly unlikely, and then HIT is ruled out at that point, and you can restart your heparin products at that point. So essentially, this chart here is going to be very important to know in terms of how to go about not only diagnosing HIT, but essentially how to treat it as well. So essentially, remember that you have to have a 4T score of 4 or more to essentially go down the pathway. However, if your score is missing components, you may potentially go along the pathway of getting a PF4 antibody if your score is less than or equal to 3. So if your score is 4 or 5, or 6 to 8, so essentially 4 or more, at that point you'll want to replace the patient's heparin with another anticoagulant that's a non-heparin moiety, and initiate your laboratory investigations with a PF4 heparin IgG immunoassay. At that point, if you come back positive for your PF4 heparin IgG immunoassay, and typically this takes about a day or two to come back in most hospitals, then you'll want to do your functional assay with the SRA. If your SRA is positive at that point, HIT is very likely. If it's negative at that point, HIT is unlikely, and you may be able to go back to your heparin agents. So if you do have a patient who you suspect of having HIT, what are some of the potential treatment options, or essentially those replacement options for heparin that we can use to treat the patient's potential heparin-induced thrombocytopenia? Those agents include Argatroban, Bivalirudin or Angiomax, and Fondaparinux or Arixtra. To start off with Argatroban, Argatroban is a synthetic L-arginine-derived direct thrombin inhibitor that is reversible. It is the only agent that is FDA indicated for the treatment of HIT. And that is important to note. So probably most of the data that we have out there is associated with Argatroban treating HIT. Its onset of action is immediately, and its half-life elimination is about 39 to 51 minutes, though in hepatic impairment, it's 181 minutes because this drug is eliminated hepatically. For initial dosing, the FDA indication says that you can start it at 2 mics per kilo per minute. However, you may actually consider starting it at a lower dose because some patients may be over-anticoagulated at this dose. The goal efficacy parameter is an APTT of 1.5 to 3 times baseline, and some people may say 1.5 to 2.5 times baseline. That APTT can be used as your efficacy parameter. But again, because Argatroban is eliminated via the liver and your hepatobiliary system, you'll want to watch out for it in hepatic and liver impairment. So say if your patient has cirrhosis, Argatroban may not necessarily be the best agent to use, as those patients may become very over-anticoagulated very quickly. Bivalirudin is another potential option that can be used for the treatment of HIT. It's a synthetic peptide composed of 2 short high-Rudin peptide fragments, and it's also a direct thrombin inhibitor, reversible binding. Of note, it's FDA indicated for patients receiving PCI or a percutaneous coronary intervention, essentially where they have to potentially get a stent. PCI with or without HIT. However, for other indications of HIT where PCI is not involved, it's used off-label. So say if your patient just develops HIT, but they don't require percutaneous coronary intervention, You can still use Bivalirudin, but technically per the FDA, it's off-label at that point. Like Argatroban, its onset of action is immediately. It has a half-life elimination of about 25 minutes in normal renal function, though in patients who have renal dysfunction of some kind, it's prolonged, with patients on dialysis actually having a half-life elimination of 3.5 hours. So in those patients, it will take a lot longer to eliminate this drug. Initial dosing of this drug is 0.15 to 0.2 milligrams per kilo per hour IV continuous infusion. And similar to Argatroban, the goal is to titrate to an APTT of about 1.5 to 2.5 times baseline. And some people may say up to 3 times baseline for your efficacy parameter. Because Bivalirudin is renally eliminated, you will not necessarily want to give it strongly to patients who have strong degrees of renal impairment, though technically we do have dosing available for those patients. So if a patient has renal impairment, the most appropriate option would probably be Argatroban, as it's eliminated mostly hepatically. Though if you do have renal impairment, you can still technically give Bivalirudin, though it's not the best or most appropriate answer. The third option we have for heparin-induced thrombocytopenia is Fondaparinux, or Arixtra. Since it's a synthetic pentasaccharide and it's an indirect factor 10A inhibitor, like Bivalirudin, it's also used off-label for HIT. Its elimination half-life is 17 to 21 hours, and it's prolonged in renal impairment in elderly patients. Its dosing, which is important to know for off-label HIT, essentially is weight-based. So if your patient is less than 50 kilos, they will get 5 milligrams sub-Q once daily. If they're 50 to 100 kilos, they get 7.5 milligrams once daily. And if they're greater than 100 kilos, they get 10 milligrams sub-Q once daily. Typically with Fondaparinux, routine monitoring of efficacy is not recommended, as it's just a sub-Q injection, though we may actually consider anti-10A levels to be obtained in the event that we do want to monitor efficacy. Another agent that we actually do that for is Lovenox or enoxaparin. An important note with Fondaparinux is that it is contraindicated in creatinine clearance of less than 30. So this is an agent that you definitely do not want to give patients that have renal dysfunction of the creatinine clearance of less than 30. Though remember, you can still technically give Bivalirudin if your creatinine clearance is less than 30. You just have to technically do a dose adjustment, though it's probably not the best answer. Argatroban would be better in that case. So now that you have your patient on one of those other or parenteral anticoagulants that's not heparin-based, what do you do once the patient starts recovering their platelets? So you may actually transition to oral anticoagulation once the platelets reach at least 150,000. And the only agent that's actually FDA approved or FDA indicated orally to transition to in patients that have HIT is warfarin. The other oral anticoagulants such as rivaroxaban or Xarelto, apixaban or Eliquis, dabigatran or Pradaxa, or edoxaban are all considered to be off-label. So FDA indication is only for warfarin. Though potentially some of these agents may be used in the future, and some of them actually maybe are used now. There's not enough data at this time to say that it's actually safe to use any of these agents. In patients who have HIT, whose platelets have recovered, you may start warfarin at a maximum dose of 5 milligrams PO daily and bridge with parenteral anti-heparin anticoagulant, such as Fondaparinux, Argatroban, or Bivalirudin for at least 5 days until the INR is at least 2. Whenever you are bridging with Bivalirudin or with Fondaparinux, and at least 4.0 for Argatroban. And the reason why we say at least 4 for Argatroban is because there's actually an interaction that occurs with the thromboplastin reagent that's used to detect the INR for patients. And there's an interaction essentially between Argatroban and that reagent. So it doesn't necessarily mean that your patient, while they're on Argatroban, will actually have an INR of 4 within their body. Actually, if you stop the Argatroban and measure the level of anticoagulation in the patient a few hours later, it may actually be closer to 2.0. And that's essentially what we have to do in those patients, is stop the anticoagulation first with Argatroban and test hours later to detect whether or not that patient actually has an INR of at least 2, because some of them may actually have a subtherapeutic INR at that point. For patients that have HIT, they need to be continued on warfarin for at least a minimum of 3 months. Because remember that HIT is a pro-thrombotic state where we may actually produce thrombosis, and as a result of that, we may need some anticoagulation prolonged. So at least for 3 months, warfarin should be on board for the patient. And obviously, with warfarin on board, patients will have to be followed up regularly for things such as INR monitoring and to monitor signs and symptoms of bleeding. These are the references for today's talk. So in regards to case question 1, we had a female come in to the ED with altermental status as a result of pneumonia. She was in the hospital for 5 days, and the healthcare team noticed her platelet count was 120,000, and it was 300,000 upon admission. She's currently on heparin 5,000 units sub-Q 3 times daily for DVT prophylaxis. Her 4T score is 5. What's the probability of HIT for patient CG? The answer here is intermediate risk. So if you remember back to that 4T score table, a score of 4 or 5 is intermediate risk. Anywhere from 0 to 3 is low risk, and a score of 6 or more is high risk. So that's why the answer here is intermediate risk, because of that 4T score. What's the most appropriate intervention to make at this time? For CG, the answer is discontinue all heparin products, obtain a PF4 heparin IgG amino acid, and start Argatroban. We don't want to start enoxaparin because enoxaparin is another heparin moiety, essentially. It's a low molecular weight heparin. We don't want to start warfarin at this time because the patient's platelet count is less than 150,000. And actually, mechanistically, if we start warfarin, we'll actually wipe out protein CNS, which are your body's natural anticoagulants, and as a result, the patient may be put in a more prothrombotic state. That's why we actually will bridge patients whenever they essentially need to be transitioned later with warfarin. And obviously, it's not appropriate to continue all heparin products because the patient does have an intermediate risk of HIT at this point. The diagnosis of HIT is not unlikely. It's just an intermediate risk at this point. So the most appropriate agents to use for this patient would be Argatroban, Bivalirudin, or Fondaparinux. Because this patient doesn't have any kind of organ dysfunction, Argatroban may be considered the best answer because it does technically have an FDA indication, though the other agents can be used as well. Which oral anticoagulant should the patient be transitioned to once their platelets recover to at least 150,000? And the answer here is warfarin, just as we just stated. The other agents, apixaban and dabigatran, that are oral agents, are not FDA indicated for heparin-induced thrombocytopenia. And enoxaparin should not be given to this patient as, again, it is a heparin moiety. You would have to wait at least 100 days for the complexes of the PF4 and the heparin to essentially wash out before you can re-challenge a patient with another heparin product, though again, some clinicians may not be comfortable doing that. If you have any further questions regarding HIT or heparin-induced thrombocytopenia, please let me know. Thank you and have a great day.